All right, welcome everyone to today's webinar. The title of this webinar is Yes, You Can Make a Difference, Integrating LSVT Big and LSVT Loud to Address the Complex Needs of People with Lewy Body Dementia. We're so happy to have you here today, and it's with great honor that we're co-presenting this webinar in partnership with the Lewy Body Dementia Association, the only organization that's dedicated to supporting people with this condition. And we're also presenting this webinar in honor of Lewy Body Dementia Awareness Month. And Julia Wood, who represents LSVT Global and the LBDA, will be sharing a little bit more information with you on what is really special about this month and their theme as well. So myself, my name is Laura Gousset. You don't see my picture here, but you can see me in the camera right now. I'm a physical therapist and I work for LSVT Global as the Chief Clinical Officer of LSVT BIG, and I'm also one of the LSVT BIG training and certification faculty, training other PTs and OTs around the globe in the LSVT BIG treatment method. Really honored to have amazing panelists with you here today, all of whom have great expertise in supporting people living with Lewy body dementia and their care partners. First of all, we have Heather Ciance, who is a physical therapist, one of our LSVT BIG faculty, and works full-time as a physical therapist at the Dan Aaron Parkinson's Rehab Center. Heather wears other hats and provides education also for the Allied Team Training Program in the Parkinson's Foundation. Also joining us is Dr. Jessica Galgano, a speech-language pathologist, who is an LSVT Loud training and certification faculty, training other speech-language pathologists, and she owns and operates her own speech practice called Open Line Speech and Communication in New York City. Dr. Jory Fleischer, we're very honored to have her here today. She's a physician and movement disorder specialist who works at Rush University Medical Center, and she has great expertise in the realm of supporting care partners and just helping people living with Lewy body dementia. And last but not least, we have Julia Wood, an occupational therapist and one of the LSVT BIG faculty. And Julia wears two hats. She's in both worlds, working with the Lewy Body Dementia organization as their director of education, and she's one of the LSVT BIG training and certification faculty as well. So I've listed all of their bios here for you. I won't take time to read them, but they are really important, and you can find them in your handout as well. Also in this webinar, you will meet several other panelists, and we have the great honor of having with us two care partners named Rick and Kim, who support people living with Lewy body dementia. And also we have Rick's partner, Deb, who is a person living with Lewy body dementia. So in the second half of our webinar tonight, we'll have a really rich panel discussion and hear from all of these individuals. In terms of disclosures, we have both financial and non-financial disclosures. I myself am an employee of LSVT Global, and Heather, Jessica, and Julia are consultants from LSVT Global, and the panelists were offered lecture honorarium. Right now, please make sure that your microphones are muted so that there's no background noise from your various environments. You can ask questions at any time by entering your questions into the chat panel. We'll answer as many of those questions as we can during the presentation, and you'll also have the opportunity to ask questions directly of the panelists during the second half of our webinar in the panel discussion time. You should have received the handout via email. If not, in about 10 to 15 minutes, I will drop it into the Zoom chat so that you can download that. We'll also send it to you after the webinar in a PDF handout form as well. So in one way or the other, we will get the handout to you. After you exit the webinar, there will be a survey that pops up. Please do take a few minutes and complete the survey so that we know a little bit about how we're doing, what the quality was like, and ideas that you might have for a future presentation. If you're a therapist joining us, please note that you can self-report this CE activity by requesting a certificate of webinars at lsvtglobal.com. This is for therapists that can self-report their CE activity to their states. These webinars are not pre-registered for CEUs. These are the learning objectives for tonight, just 4 of them. Define Lewy body dementia and understand how it's like and unlike other common neurodegenerative diseases like Parkinson's and Alzheimer's. And Julia will be presenting that information to you. Outline the role of PT, OT, and SLPs in supporting symptom management, safety, and quality of life of people living with Lewy body dementia. Clarify how LSVT Big and LSVT Loud can provide this optimal framework to address those needs. And I'll be sharing information with you about that. And then lastly, we'll talk about the benefits of LSVT Big and LSVT Loud with people living with Lewy body dementia and their care partners. And we'll do that through our panel discussion. So before we start and kick it off to Julia, we want to know more about who is joining us today. So I'm going to open up a poll. If you could just take a minute, maybe 30 seconds, to let us know who you are. And we'll go until the majority of people have had the chance to answer this poll. So just maybe 5 more seconds. Okay, and I think almost everyone has had a chance to answer it. So I'm going to end that poll and just share that with you. So it looks like about 67% of you are LSVT Big and LSVT Loud certified clinicians. And thank you for joining us today. I hope that the information that we give you today is helpful to you and will inspire you to learn even more about Lewy body dementia. Some of you are other healthcare professionals that are not LSVT certified, so welcome. And then we have a few people living with Lewy and some other people as well. So whoever you are, we welcome you and hope this information is helpful. All right, so with that, I'm going to pass the baton to Julia.
All right. Thank you so much, Laura, for introducing and kicking this off. And I just wanted to note in the chat, too, that we've got a few people joining us from across the pond. So thank you so much for being with us. So let's start out. I want to frame the discussion today. There's a lot of confusion around what Lewy body dementia is and what it's not. I think for our purposes, probably everyone's aware that it is a progressive brain disorder. And what's unique about it is that it features these abnormal protein deposits that you can see in that little slide image there called Lewy bodies. And these are like misfolded clumps that kind of glump up the nervous system and really affect the transmission and communication within the brain. And they're named simply after the neurologist who discovered them. And you'll notice there too, we've got a little umbrella when we're talking about Lewy body dementia. And keep in mind, there are different opinions about this and about it being a spectrum disorder. We characterize Lewy body dementia as being the 2 types of dementia you see there under the umbrella: Parkinson's disease dementia and dementia with Lewy bodies. And the difference in which one someone is diagnosed with is based upon the timing of the symptoms and what we call the 1-year rule. So on the next slide here, you'll see how that 1-year rule really splits kind of the condition into 2 different presentations. So we're talking about Parkinson's disease dementia. Could you all please mute your microphones, please? There we go. All right, and if you guys could keep an eye on the chat and try to keep people muted, that would be helpful. So when we're talking about Parkinson's disease dementia, this is someone who has had well-established Parkinson's disease for at least a year or more. Typically that starts with some movement symptoms, right? And then we know that over time, the research suggests that 50 to 80% of people with Parkinson's disease may go on to develop a dementia presentation. If you'll notice on the other, in that blue side of the screen there, the dementia with Lewy bodies, the development of the dementia or the cognitive impairment that can impact their daily function is at the same time or prior to those movement symptoms starting. So Dr. Fleischer, who's with us today, does a really beautiful job. She has an umbrella with a chicken or an egg under it. And it's kind of which comes first. If the Parkinson's disease comes first, then it's PDD. If the dementia comes first, then it's DLB. So hopefully that helps to unravel the confusion. So on this slide, I think it's really important to note that, there's a lot of things that people are typically unaware of. At LBDA, we call Lewy body dementia the most common type of dementia that you've likely never heard about. And we also know that it's the most often misdiagnosed form of dementia, sometimes taking multiple care providers and up to 1.5 years to get an accurate diagnosis. And the research suggests that there are about 1.4 million people living in the United States with LBD. And these are mostly adults over the age of 50, but we do see people sometimes earlier than that and younger than that. And this makes it the second most common cause of progressive dementia after Alzheimer's disease. And some research studies suggest that it's also the most expensive form of dementia based upon a lot of the complexities that we'll talk about: psychosis, hallucinations, falls, hospitalization. So next slide. So how is it different from Parkinson's? Well, with Parkinson's disease, it always affects movement. There's typically going to be that slower movement, the shuffling, the stiffness, rigidity. And we know that with Parkinson's disease, there may be some mild changes to thinking, even at diagnosis. And that later on, as I mentioned earlier, many of these folks go on to develop dementia. In the case of dementia with Lewy bodies, it always affects cognition, and they'll have one or other symptoms of LBD at diagnosis. But what's interesting is not all people with DLB show obvious changes to their movement in the early stages, and some have very little changes to their movement overall. Next slide, please. And this is the thing I find most fascinating. In our society, I feel like we really equate Alzheimer's equals dementia. And so when most people think of dementia, they think of this amnestic presentation where people don't remember their family members or their birthday or events in their life. I love this graph here that came from a research study by Dr. Tanis Furman at the Mayo Clinic. You'll notice on the top, the graphs there, those are people with Alzheimer's disease who did a whole battery of neuropsych tests, which are listed on the bottom. The bottom graph are the same neuropsych test, but completed by individuals with dementia with Lewy bodies. So you'll notice that purple bar on the far left side is the dementia rating scale. So that's a global measure of cognition. And you'll notice those two, where that purple line is shaded, are equal. But that's where the similarities really stop. When you move to the right, those red bars are memory. So notice for Alzheimer's disease at the top how low those scores are compared to the individuals at the bottom with dementia with Lewy bodies. So a much more memory impaired presentation. You go next with language, those green bars. What I find really fascinating is there's the one at the top that's really high for people with Alzheimer's, right? The co-wipe. And then down at the bottom, that's the lower one for DLB. They're literally flipped. And then as we move over to the yellow and blue bars, we're looking at attention and executive function. So you can see how the folks on the bottom with dementia with Lewy bodies, those scores are much lower than the folks with Alzheimer's at the top, and also those visual spatial measures. So literally to me, when I look at this, what it says is there's not Alzheimer's and other related dementias. It's Alzheimer's and a very unrelated and almost opposite presentation of dementia. Next slide, please. So this is something I wanted to point out because I found recently when I do in-services at a lot of places, what we're seeing is if they're doing much rehab, a lot of times it's really OT and speech heavy. And I'm like, wait, where are the physical therapists in this? Because look at this data. We know that this study suggests that the onset of recurrent falls is much shorter in DLB than even in Parkinson's disease. And there's a far greater fall risk and a shorter latency period from the time of diagnosis to when the person starts to fall recurrently in DLB than in Alzheimer's. And we also see that those with Parkinson's disease dementia and dementia with Lewy bodies have increased falls and poorer scores on those measures of gait and balance than those with Alzheimer's. So we really need to get those PTs in there, right? And when we see more severe Parkinsonism, those changes to movement, that rigidity, that slowness, that stiffness, that is associated with an increased falls in DLB. And then last and not surprisingly, when we see these abnormalities in gait and balance, that correlates with an increasing risk for falls. So if you're a physical therapist out there, there is a role for you in helping with these patients. Next slide, please. So then looking at the clinical features, I'm not going to go in depth with these, but as you can imagine, this is a very complex picture. When we're talking about cognition, we kind of talked about those domains earlier and how different they are from other types of dementia. But it's important to note that one of the hallmarks are also these cognitive fluctuations that we'll talk about a little bit more in a second. And those can be very confusing to both the care partner and to clinicians working with these individuals. With sleep, we can see REM sleep behavior disorder, where people can violently act out their dreams. That can impact the care partner's sleep as well. Also, sleep fragmentation, insomnia, restless legs at night. So it's hard for them often to get a good night's sleep. With autonomic functions, we see a lot of similarities to Parkinson's disease, the orthostatic hypotension, those blood pressure drops with changing position, drooling, issues with urinary continence, issues with bowel and bladder function, sexuality. Then we go to sensory issues, that same sensory, miscalibration that we talk about in LSVT, where they're not aware of how soft their voice is. They don't feel that their movements have changed. That's still very inherent for people with Lewy. With the motor symptoms, we've talked about these a lot, very similar to Parkinson's disease. And the neuropsychiatric, that bubble needs to be even bigger because that's one that really causes a lot of problems with hallucinations, delusions, those fixed false beliefs, also changes to mood, apathy, depression, anxiety. These can be very hard for families and for clinicians to cope with. So when we talk about these cognitive fluctuations, I think it's really important to know that you'll see somebody can have showtime, and often this happens when they go to the doctor. So they'll seem very clear, and the care partner's like, wait a minute, he was completely zoned out earlier. So we'll see those fluctuating levels, sometimes day to day, moment to moment, hour to hour, and it's not that the person's faking anything. It's literally a fluctuation in their brain function. And then excessive daytime sleepiness can sometimes accompany this. So that creeps in there too and really impacts the individual's attention and attention to task. So what is the role of rehab with this? Well, as you know, the primary goal of rehab with individuals like this is very different than someone who's had like a knee replacement or hip replacement. We're really looking to enable each person to achieve his or her own optimal level of functioning. And we compare that to what we typically think about with rehab. It's really a paradigm shift. So we're not thinking of a restorative therapy. We're not trying to cure or minimize or improve their cognition or address the underlying pathology. We're really looking at function and how we can optimize that so that person can live their life with purpose. And I love the social model of dementia care. If you're not familiar with this, I think that if you want to start, offering services more to people with dementia, you have to really look at this. And, a lot of times I think that dementia is an impairment, but a lot of the disability results from how we treat these people, how we exclude them from research, how we exclude them from inclusion in groups or in society. And that almost suggests that the condition is the fault of the individual, which of course it's not. So we really want to focus on their skills and abilities, those strengths, rather than their challenges and losses. They can be fully understood. So you have to really work it. The onus is on us to communicate and to really try to get their history, their likes, their dislikes, and understand who they are. We want to create a really supportive environment where we enable them to do the things that they want and need to do. And that goes a long way with communication. And you've got to work on that communication with both the care partner and the person with LBD, so you can really collaborate as a team. And then we want to look for any opportunities we have to rehabilitate and also re-enable. So basically, we're looking at, we don't necessarily have to get them back to independent with everything, right? They may need accommodations or modifications or adaptations, or maybe they need assistance. What is the optimal level for that individual for that task at this moment? And I love this. This was a systemized review of randomized controlled trials that looked at, if we work to optimize the environment and the activity, we support the family carers, we look at being needs and goal-based, really what are the goals of the individual? And we then enable self-management where that's possible. These are the models that are shown to be most effective when working with individuals with dementia. So how do you know if therapy is needed? Well, I mean, with physical therapy, like I said earlier, we can think about, has their movement changed? You know, we see the small, slow movements. We see that reduced arm swing, the shuffling gait, poor balance, falls, freezing, difficulty getting in and out of beds or cars or chairs. Those are all a tip off that we need to see PT. And I think really at diagnosis, because a lot of these are how the person's diagnosed. We're talking about speech therapy. We're looking for those maybe soft voices, hoarse voices, maybe problems with memory or slow thinking, some slurring or mumbling of speech. But we also want to think about swallowing function as well. You know, how are they doing with swallowing pills or drinking water? Are we seeing some coughing or pneumonia that's happening? And then last, but certainly not least, we're looking at occupational therapy. We're looking at any difficulties completing their activities of daily living, also those instrumental activities like shopping, you know, leisure, social engagement, all of those things that really help someone live their life with purpose and meaning. So I think all of this really spells out a complex progressive condition deserves a strong and ongoing team support. So they really need the whole village, all hands on deck. And we think about these interprofessional interventions here, can look at a lot of the crossover. Often I'm working with my speech colleagues and how we can best address scaffolding, the supports for cognition. With physical therapy, we're going to be talking about their mobility and gait and falls within their daily living task, within their community. And it really takes all of us working together to promote that safety and optimal function. And with that, I will hand it over to Laura. Thank you all so much.
All right. Thank you so much, Julia. Most of you in the audience are already LSVT Big or LSVT Loud certified, but for those of you who aren't, we just want to give you some brief information on what LSVT is and how that might be used to help people living with Lewy body dementia. So these are therapy protocols, and you may be familiar with other types of therapy interventions. So we really want to focus on what makes them unique or different from other therapy interventions you may be familiar with or may have received in the past. As Julia said, the movements that are associated with Lewy body dementia are very similar to Parkinson's disease. They make movement smaller, voice softer, and LSVT Big and LSVT Loud really intentionally counteract this by training movement that's bigger and voices that are louder and healthier. They also are not just exercises that focus on movement or loud voice. Very purposefully, they address many of the complex non-motor symptoms that you see both in Parkinson's disease and Lewy body dementia. These are individualized treatments, so they do have standardized exercises, but they're very much personalized as well to each person's goals and to each person's level of ability. And lastly, one of the things that we're most proud about is the level of research that has been done on the LSVT protocol specifically over the last 30 years. These are three key features that make them unique. One is the focus on amplitude. Many therapy treatments incorporate amplitude-specific exercises, working on bigger movements and louder voices, but with LSVT Loud and LSVT Big, it's our sole target. Doesn't mean that that's the only thing that improves. Many things improve, but that's our sole focus, both for the patient and for the therapist. The mode is intensive and high effort. We know that that's required for neural change and physical change as well. And we support people through that. And the goal is calibration so that they know how to use bigger, healthier movements and voice in daily life after therapy, and it doesn't just all dissipate. So this is a kind of just a little schematic on what happens with this cue of loudness. When you're targeting loud, there's many things that improve, respiration, articulation, mouth opens more, and really we're driving the whole central nervous system with a single cue of loud with the goal of not shouting, but resulting in a healthy loudness. The same thing with physical movement. People with Lewy body dementia may come in with a multitude of different impairments, reduced arm swings, smaller steps, slower walking speed, changes in posture and balance. And through the single cue of loud, or big, excuse me, we expect improvements across the system. So bigger posture, bigger arm swings, faster gait, longer steps, etc. The mode is intensive. This treatment protocol is researched at a dosage of 4 sessions a week for 4 weeks, 1-hour sessions. They're all done one-on-one, so it's not a group therapy. It's not a community-based exercise class. It's really very much individualized to each person. They do daily homework, and it's always delivered by therapists who are certified in the LSVT Loud and LSVT Big techniques. They're customized to the goals. So for LSVT Big, for example, we can not only adapt the exercises for varying levels of ability, but we really dig in to find out what's important to you. And that may be something like, being able to go to restaurants or being able to get in and out of bed independently or with less help. And for communication, it might be very customized goals related to communicating at work, at home, with family, or in the community. So one of the things that LSVT Big improves is amplitude, but that also works on other things like directional changes, being able to start and stop movements, building endurance, improving balance, posture, walking, and ADLs, and all of these are supported by literature. LSVT Loud likewise improves a myriad of things as well. Not only the loudness or the amplitude of voice, but articulation, the vocal endurance, speech clarity and articulation, intonation, and other things. Our goal is that people know the effort required to use more normal movements and more normal voice in daily living. Like Julia said, there's a sensory deficit that's really common in both Parkinson's disease and Lewy body dementia. Oftentimes, the person living with that doesn't really realize that their voice has become softer or their movements have become smaller. And so our goal is to recalibrate their system so that they're moving in a more normal way after treatment. One of the reasons that the LSVT protocols might be a really good fit for people living with cognitive impairments is because it's one simple cue. They do not have to learn a lot of complex instructions or procedures. It's whatever I say, I'm going to think loud, and whatever I do, I'm going to think big. And that can spill over to really generally any activity or communication activity. Our way of teaching is through modeling. So we say, hey, just watch how I'm doing it and you do it the same way. So they don't have to memorize a set of procedures. The exercises are easy to learn. There's a high level of repetition of practice that reinforces the behavior, and they work on functional skills that are meaningful to them. And this results in the person being very motivated to exercise and work hard and empowered as well. So for care partners, there's a few things you should know. The earlier, the better. Don't wait until symptoms are severe or till late in the stage. It's easier to prevent and maintain than it is to restore, but it's never too late as well. People with Lewy body dementia can improve their function, and they can be empowered to become more independent. General exercise is vital for people living with dementia. However, it doesn't replace therapy. People need both therapy and exercise. If your loved one is going through LSVT Big or LSVT Loud, the cueing is really simple. It's just think big or think loud, and your therapist will work with you on that because it does take some practice. So go to sessions if you can, observe therapy, and if you want, on the LSVT Big Homework Helper DVD, Volume 2, there's a chapter specifically for caregivers. Because Lewy body dementia is a chronic progressive disease, we really embrace a lifelong model of care. So you won't be just meeting your therapist for 1 month and never again. It's a plan of care that enables you to be able to keep in touch with them long term and live your best life ongoing. So that is not only the 1 month of treatment, but also doing daily exercises, possibly doing group exercises called Big for Life or Loud for Life, where you're socially engaging with other people who have gone through these programs. And then, just like you go back to the dentist every 3 to 6 months for a checkup and a cleaning, you go back to your LSVT therapist every 3 to 6 months for a checkup, possibly a few visits to keep you moving as best as you can and speaking as best as you can as well. LSVT Global has a number of different tools to support homework practice for people living with Lewy body dementia and to also ease the burden of the caregivers as well. We have homework helper videos, so you can just pop it in or push play on your tablet or TV and follow along with those exercises. We have a program with a company called Physiotech that also enables you to do your exercises video led. LSVT Loud has a software system called the Coach, which makes it super, super simple to do your LSVT Loud practice at home in a very personalized way. We have an online exercise platform called LSVT for Life for people who have gone through the treatments. And also in many communities, there are LSVT Big and LSVT Loud certified clinicians who are actually holding physical Big for Life and Loud for Life exercise classes in their community. If you want to learn more, I won't go through these, but we have a ton of information on our website and blog, and I've popped in a couple of QR codes. So if you want to not type in the long URL, you can go directly there. If you're ever looking for a therapist, we've trained about 50,000 therapists in 80 countries. And well, hopefully there's one in your area. You can go to our website, click the red button, put in your geographic information and see if there's one in your area. If there's not, you can contact us because sometimes we can find people on the back end who simply aren't listed. And sometimes there's also people that can deliver therapy via telehealth. I'm going to pass it back to Julia just for a little information, and then we're going to get to our panel.
Excellent. Thanks so much, Laura. And so, as Laura mentioned earlier, with the Lewy Body Dementia Association, we're a national nonprofit dedicated to outreach, education, and supporting research for people who are affected by Lewy body dementias. To learn more, you can visit us at www.lbda.org. And then if you remember nothing else from the talk today, please take down this number, this email. Our Lewy line is 1-800-539-9767, or you can email us at support@lbda.org. So this is your go-to connection for two licensed social workers who man our phone lines. They are there to support people living with Lewy, care partners, help you find resources in the community, but also clinicians that may have questions. And we will route you to who we need to route you to get the right answer. You'll see our support groups there listed. So this is a great contact for you to keep on speed dial. And then we have a lot of educational resources. You can scan that QR code there and find resources that you're able to download and print, or you can also reach out to us and we can mail you copies to send out at your office or give out to patients or clients. And then here's a great QR code. If you want to learn more, if this was just like glossing the surface, then we have a 4.5-hour masterclass on Lewy body dementia that is interdisciplinary. So it's Heather Cianci, who you'll hear from in a moment, myself, and Heather Hodges. And then if you want to see our webinars, you can take this QR code, and we've got several community webinars throughout the year that we've recorded that you're welcome to come and watch. And I think that's it. Yeah, we're going to the panel.
All right. All right. Well, that was very quick and fast. So I hope you guys held on tight and got some good pearls of information there. I'm going to go ahead and stop my screen sharing, but during this panel discussion, I will be asking some questions. And if you have some specific questions for the panelists, now is your time to type it in the chat and ask, and we're going to get through as many questions as we can before the webinar is over at 3 p.m. Eastern. So just give me 1 second to highlight everyone so that you can see everyone. And as I'm spotlighting you, if you want to just introduce yourself, so go ahead, Heather.
Hi, everyone, and thank you for joining us. My name is Heather C. Yancey, and as Laura said, I am a physical therapist. I work at a Parkinson's Rehab and Movement Disorder Center in Philadelphia. Julia and I used to be co-workers in the clinic, and now we're still co-workers through many different online educational events like this. So happy to be a part of this.
All right, thank you for being with us, Heather. All right, I'm going to add Jessica, if you want to give us a quick intro of you.
Hi, everyone. It's very nice to be with you here today. So my name is Jessica, Dr. Jessica Galgano, and I'm greeting you from both New York City and Los Angeles, where I run a private practice called Open Line Speech and Communication. We provide speech therapy and swallowing and respiratory voice services to individuals with neurologically based difficulties. I have been an LSVT Loud faculty instructor and clinical expert since 2010, and I am so happy to be here with you today. LSVT Loud has really informed and transformed the clinical practice that I do with my patients and my clinicians do with our patients throughout each city that we work in. And so we're really excited to be here with you today talking about this.
Thank you, Jessica. We're glad to have you. All right, and next I'm going to introduce to you Dr. Jory Fleischer.
Hi, everyone. I'm Jory Fleischer. It's such a pleasure to be with you today. I am a movement disorders neurologist by training and also a researcher very interested in how we help people with Parkinson's, Lewy body dementia related disorders and their care partners thrive and improve their quality of life with these diagnoses. I have been introduced to and a follower of getting all of our folks involved with LSVT Big and Loud since I was in training back in 2009 with Heather and colleagues, and just find it to be so beneficial for all of my patients and families.
Thank you, Dr. Fleischer. All right, and now I'm going to bring on Deb and Rick, coming all the way, I think, from the East Coast, right?
Yep, we're in Everett, Pennsylvania. I'm the caregiver, and this is Deb, my wife. She's actually having a tough day cognitively today. She's changing cognitive drugs, and it's given her some difficulty. But it's the life with dementia with Lewy body.
Well, we're honored to have both of you here today, and thank you for taking the time to be here, even on a bad day. Yeah. All right, and last but not least, we have Kim, and Kim is from Colorado, I believe, and Kim was a caregiver for her brother, but I am going to let you tell your own story, Kim.
Hi, I'm Kim, and like you said, I was caregiver for my brother for about 3 years, and I just want to say that LSVT Loud made a huge difference in our lives for the last 3 years. It was one of the biggest things for us to help care for Nelson and have him stay engaged, communicating with us, and just much better quality of life because he was referred to LSVT Loud and a little bit of LSVT Big that also helped him immensely.
Thank you, Kim, and I can't wait for people to hear your story. I got to hear a little bit yesterday during our webinar, and it was really, really inspiring. So let's start with you, Dr. Fleischer. As a movement disorder neurologist, you see plenty of people with a variety of movement disorders, including Lewy body dementia. What prompts you to send a referral for either LSVT Big or LSVT Loud?
It's such a great question. And I think as much as you can meet one person with Lewy body dementia and you've seen one person with Lewy body dementia, the reasons for referral can really cross that spectrum too. So if people are starting to fall, if people are on, having a lot of near falls, if I see as they're getting up that they're kind of holding on to everything in the office, or if we're doing home visits or telehealth, I see that someone is kind of cruising between pieces of furniture, we need to bring in some LSVT.
Please go ahead and mute your microphone, everyone. Thank you. All right.
If people are experiencing a lot of freezing of gait, where they, stand up and might get stuck and their feet are kind of stuck in place, or they're noticing that they're getting stuck as they're going through doorways or changing transitions, being in small spaces, I think that's another reason we'll frequently send people. Or if they're transitioning from one home to another home and having a hard time with that and struggling to sort of adjust to that new environment and know how to move in that environment, that can be helpful. And then similarly, struggles with communication, especially if it's being able to speak loud enough, or what very commonly happens is the care partner goes, my loved one is not speaking loudly, I can't hear them. And the person with LBD goes, I'm speaking loudly, I think they need their hearing checked. It can be both. But I think getting LSVT loud involved at that point can be tremendously helpful.
Okay, thank you. A couple of follow-up questions, then we're going to go over to some of our other panelists. But do you see the same type of motor fluctuations that can be seen in Parkinson's disease, or do you find that it's a little bit different with Lewy body dementia?
It's a great question. I was actually just talking with one of our trainees yesterday about this. So motor fluctuations, sort of that really sharp response of, I took my pill. Usually we think about this as levodopa. I took my pill and within a certain amount of time, aha, I can move better. My tremor's gone if there's a tremor, all of those kind of things. That tends to be more blunted in folks with dementia with Lewy bodies. And again, it's sort of that chicken and egg. If someone's got Parkinson's for a long time, and then they're developing dementia, we may still see those motor fluctuations in response to the doses of medication. If someone is starting more with cognitive, we tend to see less of those direct, really pronounced fluctuations. They can still happen. But what I see more often is the person with Lewy body says, I don't really know if the meds are working for me. And then accidentally goes on vacation, meds get lost, something happens, they miss doses for a couple of days, and the caregiver often is like, whoa, there was a big difference. And so sometimes the only way we know it's doing something is when the meds are missed for a while and we go, wow, there is a difference. They are doing something.
Yeah. Okay, good point. Thank you. I'm going to come back to you in a minute, but I want to go to Kim right now. Your brother Nelson had not only LSVT loud, the whole protocol, but then he was seen kind of ongoing long-term for periodic treatment and sessions to help keep his voice strong. Can you speak to the audience? A lot of them are LSVT loud clinicians listening. It'd just be great to hear from you, like what was the impact on his quality of life as a result of going through LSVT loud and continued tune-ups, we shall say?
Yes, he was diagnosed when he was living in Cincinnati and working at the university there. And he was right away referred to by his medical team to speech therapy and LSVT loud. And he began telling me about this on the phone. It was the most important part of his week at that point but I think it was the intensive program is what he did when he was in Cincinnati, but I wasn't involved. So when he moved to Colorado, because he had to leave his job and he moved in with me, the first thing he asked me to do is get him linked up with LSVT loud, which I did. It wasn't really referred by the doctor, it may have been, but what happened then is it sounds like it was called a maintenance program. And it was every single week he would meet. Because of the pandemic, it was on Zoom, unfortunately, but it was fantastic. What would happen is we did practice during the week with me, and it was good, but it was not nearly as successful as meeting with a therapist. So we would get him in a quiet room. I helped him with the technology of the iPad. And each week he would prepare for the individualized attention he would get. because we would have a series of questions that helped him communicate with us, like, I would like to go for a walk, or I would like coffee, or can I give you something? So these sentences that he practiced every single week helped him to remember to say them loudly. And then the other part was something individualized, like she heard that he had just gone on a camping trip, so she would ask him about it, and she would remind him to speak loudly. And so after each session, Nelson was more engaged, he was happy, he was prepared for life, and he could speak in a way that the rest of our family could understand him. And as the week went on, even though we practiced, he would start to mumble again. And so it was critical all the way to the very point when he couldn't hardly speak at all. It still made a huge difference for him to meet with a therapist weekly in a maintenance program.
Wow. That's great to know that it kind of followed him throughout the course of his disease and still was meaningful to him, important for his basic communication needs, even towards the end.
Yes, that even when he wouldn't speak to us anymore, after he had a session and he could say some words during his hour session, then he could say the words to us. And that just made us all so happy, and we could just be with Nelson and hear his voice again. And it was important to get the large earbuds that were headphones over his ears so that he could remain focused on the iPad, because it was hard to stay focused as the disease went on. But if we got him to focus on the iPad, it was tremendous for years. So I really recommend it.
Amazing. Thank you. Let's hear from Rick and Deb, if you're able to. What are some of the changes that you experienced as a result of either LSVT Loud or LSVT Big, or both, whatever comes to your mind today?
Yeah, well, she did the LSVT Big first. These were prescribed by a doctor at Johns Hopkins that we were going to for a second opinion. That's one of the centers of excellence for Lewy Body Dementia. And she was going in with, she had, the typical Parkinson's stuff with the shuffling gait and the bad posture, low voice, that kind of stuff. And the focus was on trying to improve those things. She also had issues with both hallucinations and other visual things like double vision and depth perception and things like that. So the clinician had to address some of these things by putting extra cues around the room and things like that to make it work. But she came out with better posture and arm swing a little bit, anyways. She has a walking group that she goes out with, and they noticed, and her yoga class also noticed that she was improved in certain areas, including posture.
Excellent. Well, I'm happy to hear that. Those are all really meaningful improvements when it's about mobility and basic function every day. Dr. Fleischer, do you see any changes in the patients that you've seen that have received either of these treatments? Is it noticeable, or is it somewhat subtle for you?
I think as long as people are doing it and they're kind of sticking with the program, and especially those who have care partners, whether that's family care partners, their primary person, or it's, a hired person who sometimes not the closest person to them, right? It's easy to say no to a spouse, partner, adult child. It's harder to say no to someone who's sort of coming in from the outside. But if there's someone who can help prompt the person to really practice, absolutely. I mean, I think, as a movement disorder specialist, we notice really subtle things. We're not good at parties, right? We just kind of stare at people's movements and go, right? And so, just that first second of walking into a room, we can see how a person is sitting. If they're, we know that their posture was like this last time, but they're sitting, even if they're putting on the show for us, they're still able to do that in that moment. We see how they get up from the chair, right? Is it multiple kind of
Yeah.
scoots and, attempts, or are they leaning forward, planting their feet, and they really know how to make that big movement and get up? It's
Mhm.
how they answer the question, not just volume of voice, but are they turning? Are they making eye contact? Are they what my kids call, whole body listening? And I feel
Yeah.
like that's also worked on in LSVT Loud. And I see that from moment one. So it makes a huge difference. I think sometimes for care partners who are there day to day to day, it's hard to see those changes.
Yeah.
But I will tell you, as someone who, sees people, a few months apart, sometimes we can see a big difference.
Yeah, that's really reassuring, and I think that's a good point that you make that, day to day you might think, is it really helping? But when you step back and haven't seen someone for a while, it's much more apparent. You said something important about, as long as they continue with their exercises. We totally agree with that. As therapists, it's like exercise is medicine. You gotta do it every day if it's going to help. With that comes tune-ups, and do you typically recommend that your patients go back to their therapist for a tune-up periodically, and what does that look like?
So I think, if I could design the healthcare system,
Yeah,
which is a big if I could design the healthcare system, right, people with Lewy body, people with Parkinson's would have continuous access to the therapies they need all the time.
yeah,
Period.
yes,
That's not how our healthcare system works right now. Call your senators, call your Congress
yeah,
people. Truly.
yeah,
Because most of the time, people are getting this huge benefit. And then, whether it's covered by Medicare, whether it's covered by Medicaid, there's a mandatory sort of waiting period in between when you can start the next, right? And that's when we need care partners or friends or neighbors to, be sort of reinforcing everything that was learned. But yes, as soon as we hit that often mandatory sort of 12-week waiting period,
mhm,
right back to it. If we can
yeah,
do that, I will tell people, if you're not scheduled to see me for more months than that, you can send me a message, remind me, I will send in that order.
yeah,
As much as we can get people
mhm,
what they need.
mhm.
It's sort of a demand and supply challenge, but we know that there's benefit.
Yeah. Yeah, definitely. And Heather, I mean, you're always our greatest spokesperson for there is no cap for Medicare, right? And can you just remind the audience that might not be familiar with that, what that legislation looks like and what Medicare actually says
That's
for
it.
therapy?
Excellent. Thank you, Laura. Yeah, I'm sitting here shaking my head as Dr. Fleischer's talking.
Yeah.
Yes, people need to know this. And it's not just for therapists to be aware of it. I think individuals living with Lewy body dementia and Parkinson's need to be aware that Medicare no longer has a set amount of money that we can use for therapy, right? It used to be called a cap. What it comes down to now is that it is the diligence of the therapist to say, my patient has needs. My patient needs me to help them do these things, not necessarily as though what Julia said before, we're not looking to necessarily rehabilitate people, right? Maybe to completely improve them and make them fully independent. We're not going to be able to do that with many people. But if we can be preventative maintenance, if we can keep people from falling, if we can keep people from having aspiration pneumonia, if we can keep people, like Kim was saying, for her brothers just to be able to communicate his needs, that is something that is 100% covered by Medicare. And what it comes down to is the documentation of the therapists that are working there. And I can tell you, I will be doing movement disorder care now for 30 years. The majority of my patients have been covered by Medicare, and we are very stringent about how well we try to fight the fight for people, because the healthcare system is just not kind to a lot of people. So we really take it on ourselves as therapists to be able to do that. So please don't fear that. Know that you can always have justification. I can tell you right now, I have several patients who are on sort of a continuance maintenance program with me once they have actually completed a course of LSVT Big, where I see them once a month for years. And again, sort of like Kim said, the family can be super helpful and it's so empowering and what we need, but people will do a little bit better when their therapist.
Yeah.
So we tend to
Yeah.
be a little bit of sand in their shoe.
Right. Right. Good sand. Good sand. Yeah. All right. We're getting, gosh, this goes so fast. I want to ask each of you, Julia and Heather and Jessica, a question, because we have a lot of LSVT certified clinicians in our audience. I'm sure many of you have treated people living with Lewy body dementia. And one of the questions we often get is like, what's the prognosis? Like, can I really expect them to get better? And two is, what are some things I might need to do a little bit differently for a patient living with Lewy body dementia? So Julia, can you go first, and then we'll go Heather and then Jessica.
Absolutely. So definitely, some things that I talked about even last night was that often in our clinic, when I was with Heather, we'd have music going. There's multiple clinicians in a room. You can hear the commotion at the front desk, and that could be really distracting. If you remember back to that graph I showed in the beginning, those attentional deficits can really be a problem. So a lot of times I would take my individual, and not even always with Lewy, sometimes it was Parkinson's, and they even had some cognitive issues, but into a private treatment space where I could control the environment, the sound, the light, a lot of that, a lot more. And then you can layer in those challenges as more kind of that real world environment later on. I think also it's really important to think about how you're setting your goals. I think that's where a lot of therapists have difficulty is, for example, they may not be able to do the 5 times sit to stand within the time that, would be considered, not a false risk, but can you make it to where they only need a verbal cue or a tactile cue rather than physical assist to get out of the chair? Those kind of things are still improvement. You're showing improvement, but it's looking at a realistic improvement and what that's actually going to be. So I think it takes some experience for sure. And definitely probably some trial and error. But a lot of it is around appropriate goals and then making sure you set them up for success from the very beginning.
Awesome. Awesome. Heather, you're next.
Ditto to everything Julia said. And the beauty of LSVT Big is its task specificity. People get better at things that they're having difficulty with when they actually practice that. So a lot of times it may be that I'm increasing the number of times and repetitions that I'm doing it. I'm minimizing a lot of my talking. I love to talk. I love to kind of engage my patient, but like Julia said, sometimes you need to bring it down. You need to keep it simplistic. And I think the other thing is the sort of goal. What is the reward of what we're doing? So always talking to my patients about, this is why we're here. This is why we're doing it. Let's talk about what we're going to do at the end of the day today and how this is going to help you make it better. So always kind of solidifying the rationale behind what we're doing and why we're doing that to help them have, again, I use the term quality of life all of the time. What do you want to be able to keep doing? What's going to keep you joyful and happy?
Perfect. Yep. And I think that's what we heard from Kim, right? Is just making it super, super salient to the person is so important. Jessica.
Gosh, I don't know what I can say that will add any words of wisdom to this wonderful information we're getting from everyone today. I think what I can add is, to just stick with it. I think over time and day to day, there are going to be good days and there are going to be bad days. Sometimes you just wake up and it's going to be a great day, and other days you wake up and it'll be more challenging. And I think it's important, no matter what day that is, if it's a good day or it's a bad day, you still get up. You still know that there is a big community of individuals here to support you, to support your care partners, to help you in every way that we can. And so when you're struggling with these visual difficulties and you can't sleep right and you can't seem to walk right and you forget how you make your coffee in the morning, that's okay. To take some deep breaths, to stop, to know that we are here for you, and exercise is medicine. And maybe it's a good time to just go back and get into some of those exercises that will work for you, that you're familiar with, that you're comfortable with, to show yourself, hey, I can do this today. And hopefully from there, that gives you the inspiration you need, that motivation you need to just make it through that day till the better day arrives. So just stick with it. These fluctuations that are experienced, they come and go. And so we just work together to get our strategies or to use our strategies in the best way we can day to day. So just stick with it. It can be challenging.
Thank you, Jessica. That couldn't be more true. And that goes for a lot of different conditions, doesn't it?
Yeah.
Yeah. Okay, Dr. Fleischer, I think that you have a little comment that is very important to address regarding blood pressure. And then I just love to hear, like, what's your top take-home message that you want to leave everyone with?
Sure. So this is the blood pressure issue is not specific to LSVT, big or loud, but it's just kind of a comment for folks who are, working with people with Lewy body or people with Parkinson's or people with MSA in the clinic. And you may know that they can be susceptible to what's called orthostatic hypotension, where blood pressure kind of drops really quickly with posture changes, or they can have really high blood pressure. And one thing that I would just say is being really mindful of the fact that for most people who have that symptom, it is not new that day. And what I see really often is, the patient comes in, they're ready for therapy, their blood pressure gets checked as just sort of a matter of routine, and it's crazy high, or it's super low, right? And there's often a wait, stop, hold on, we're gonna, calling. I've had people frequently, sent to the emergency room, 911 called for blood pressure fluctuations that while they look scary, that is that person's norm, right? And so just the same way that if the person comes in and they are speaking really quietly, right, or they're, not doing something, we always stop and check and go like, are they having a stroke? Or is this their norm? Is this part of the disease for which they're seeing me, right? And we don't necessarily send them to the emergency room for one reading that one snapshot in time. So I think just keeping in mind, if, it's great that we're checking vitals, they're vital, but how do those vitals fit in with that person's norm? And if you're concerned, I would always ask, ask the care partner, ask the person, reach out to their treating physicians before sending someone to the emergency room, because by the time they get to the ER, they've often gone the other direction, right? And so they're sent in for low blood pressure and they get there and they're high, or vice versa.
Yeah.
So I think that can be really challenging for patients and families because they're losing the benefit of therapy because this, what seems like an acute issue, sometimes it derails everything else.
Wow. That's actually really, really important for all of our therapists to know, because they might not be really familiar or aware of that.
And if there's a question, electronic blood pressure cuffs can fail our people, especially if they've lost a lot of weight. So if their weight is less than their age, please consider using a pediatric cuff. I'll just put that out there. But the main takeaway is this works.
Okay.
It works. We don't have a ton that works well in our folks with Lewy body. We don't have a cure yet, but we can manage symptoms and we can improve quality of life. And these are some of the biggest tools that we have. So.
Well, thank you, Dr. Fleischer, for just saying that, for your support. And, we're all therapists, and gosh, if we can do anything to help people living with a devastating disease, that's what pulses the blood through the heart of therapists, is to know that you're doing something that is helpful and helps people with their quality of life. So thank you. Deb and Rick, final words that you'd like to share with our audience.
Given that your audience is mostly clinicians, I think it's important to recognize that somebody coming in with a disease like dementia with Lewy bodies has missing cognitive abilities, and in particular, executive capacity. They have a difficult time doing like the advanced exercises where you switch back and forth between sides. That becomes a multi-step process, and multi-step processes are very difficult to execute for some of these people. And then there's the whole the visual side of it that goes along with this disease. And you might need cues, and with loud, you're going to need bigger text sometimes, that kind of stuff. We did that via telehealth, and you could scale it up on a computer easily. But if there's handouts or something that are used in person, think big.
Think big when you're doing loud. I love that. Well, I think those are important messages that you can do LSVT big and you can do LSVT loud, but think about the adaptations you might need to do to make it feasible for that person. So thank you. All right, and last but not least, Kim, you've already shared so much with us, but as a care partner, someone that's, had vast experience observing the effects of LSVT loud with your brother, Nelson, what are your final words that you'd like to share with these mostly clinicians in attendance?
Well, I like what Rick said. It's such a challenge to make that connection, and because of the cognitive issues that are going on. But for Nelson, his language skills were still good if he was speaking. And we had such respect for him, and he had so much respect for himself. And so the fact that the therapist was so connected to Nelson, and so even if he was having a day with some delusional thoughts, she would just go with what he had going on in his head, and so that gave him the confidence to speak out what he was thinking and to get that higher quality of life for himself, so that we could also enjoy his stories and his ideas, and even if they weren't completely grounded in what was happening, at least he was then engaging. And so that was just another piece of it that I think Rick is alluding to, that if I have your name right, that it was a challenge, but such a benefit to us to have him be talking to us again. So I just hope that people get referred to LSVT loud and big as much as possible, because from our experience, it was just huge for the last few years.
Well, that means more than anything that we could say as therapists and as healthcare providers, because you saw it firsthand every day. So thank you for that. We're out of time for our webinar today, but a lot of you have typed in questions. I think that our panelists have answered most of them via chat, so thank you for that. But if you have additional questions, either about LSVT loud or LSVT big, or about Lewy Body dementia, please go ahead and contact us.
Just to do on your floor.
There's somebody's microphone that's not muted right now. Thank you. If you could just go ahead and contact us at info@LSVT Global, or Julia has graciously offered her personal email here, jwood@lbda.org. We're happy to point you to resources. Maybe you have personal questions that you'd like to send us. Whatever we can do to support you, we're really happy to do that. There is a survey that will pop up at the end. If you're a live participant today, for an on-demand participant, here's some instructions for you as well. So with that, we just really thank you all. Again, thank all of our panelists for taking the time to join us today, and to our audience, I thank you for attending. And I hope this was a useful webinar to you. I hope it was encouraging to you, that whoever you are, that there's hope for people living with Lewy body dementia. So thank you. Goodbye.